I tried to look for like some sort of fun fact when it came to abdominal trauma in pediatrics, and I have to be honest, like it kind of got depressing when I tried to look, so I shifted to the adults. And I thought, we're here in Vegas, the city of mayhem, music, and magicians. And I came across this pop culture kind of thing about Harry Houdini. You cannot talk about magic without talking about one of the grandfathers of the magic era, right? How many of you heard that Harry Houdini died from a ruptured appendix? How many of you heard that Harry Houdini died from blunt abdominal trauma? It's one of the great mysteries, if you will, or I don't know if it was so great, so it's at least a bit of a fun fact. So he was at this conference speaking to some medical students, and he had this thing where he was like, I am so toned and fit from escaping all these like fancy different things that I will let people just like punch me in the stomach. Right? So he went and he, med student goes, can I punch you in the stomach? He goes, yes. And he went for round 1, no problem. He went for round 2, and before he had a chance to tighten his abdomen, he got punched in the stomach, and it really got him. So much so that he had to stop the med student before he went into 3. He knew that the show must go on, even though he was having a fair amount of pain. And when they tried to get him checked out, they said, we think you have a ruptured appendix. You need to go to the hospital. He said, no, the show must go on. And went on with the show, got sicker and sicker and sicker, and ultimately got diagnosed with a ruptured appendix. They had it taken out, but unfortunately, he ended up dying of severe sepsis and peritonitis. Now, the thought was, did he actually cause a ruptured appendix with the blunt trauma? And they thought, really? It happens pretty rarely, but it was certainly kind of one of the debates of how did he die. We know he died from a ruptured appendix, but did the blunt trauma cause it? Who knows? But it was the only fun fact I could come up with in the setting of pediatric trauma, so guess what? You are privy to it. Moving on, let's talk about the susceptibility. Kids are a little bit different, and mostly because they have less fat padding, larger solid organs, and less space. So for those of us who have enjoyed a Las Vegas buffet, we're not overindulging. We are protecting against organ injury. And that's what kids have, right? They have nothing protecting them, and so they're just more prone to different kinds of injuries. The most common which are MVCs, pedestrian versus auto, falls, bicycle injuries, and on down the room. And we've mentioned this over and over again, and that really highlights the importance of spreading it out longitudinally for that general reminder of always think abuse. Presentation and assessment, it's fluids and blood, really, is the end of the day. If they don't respond to that, oftentimes they need surgery. The intra-abdominal injury signs can be absent and patients are stable. Now what do we do, right? The ones that clearly are unstable and crashing, those are almost the easy ones. The ones that are in the in-between, what do we do? How do we manage this? How do we balance some of the clinical decision rules that are out there with what we're seeing in front of us? So PCARN's group essentially came out with a lot of the signs and symptoms that help maybe direct us to increase our suspicion of clinically significant intra-abdominal injury, like tenderness or pain, abdominal wall ecchymosis, low GCS, vomiting, elevated AST and lipase, abnormal chest X-ray, as Sujit mentioned earlier, and some chest wall findings. All of those portend an increased risk of clinically significant intra-abdominal injury. Now, keep in mind that those original criteria didn't include any labs. It didn't include an ultrasound. And if we add those factors in, we have a chance of catching something better. And what thresholds do we use? ASTs of greater than 200, ALT of greater than 125. Now, unlike adult patients where the literature really is all over the place regarding the utility of LFTs in blunt intra-abdominal trauma, in pediatrics, this has been incorporated in most of the algorithms and guidelines and recommendations. So in kids, you have a stable-ish kid, you kind of assess them, you say, all right, well, I see some signs that I mentioned before, like the tenderness, the pain, the vomiting. Let's go ahead and get some labs. For an adult, you might say, I'm just gonna scan them, right? The kid, you're gonna get the labs first. You're not automatically gonna go to scan, and we'll talk about why. The sensitivity of this is still fairly low. The specificity is much higher, even when we incorporate the blood work. And we start to improve and change that as we change the thresholds of AST, but a commonly used one, again, is AST and ALT greater than 200 and 125, respectively. The big caveat is if abuse is suspected. If you suspect non-accidental or inflicted trauma, your thresholds are much lower. Your AST and ALT greater than 80. Not the 200 or the 125, greater than 80. Now, we always say, hey, don't give them the radiation. Be careful about too much. We have ionizing radiation, risk of malignancy. If you are worried about abuse, if their LFTs are greater than 80, I give you permission to light them up. And I say that a little half-heartedly. But the point is imaging. They are much higher risk for intra-abdominal injury because we don't know when that injury occurred, right? Somebody, a parent or a caregiver is holding the baby and they tumble down the steps, right? And they said, oh, they must have just fallen down the steps themselves. And you say, wow, they've got some signs, they've got some tenderness, I'm gonna get some LFTs. And then you notice that they're 90, maybe 100. You know that the threshold's higher, but you go back and get the story and they're like, yeah, I don't know, maybe I didn't see them actually fall down the stairs. I don't actually know what happened. Actually, wasn't home that day. That's odd. In that child with a changing story, the unexplained phenomenon, I'm going to increase my threshold. The flip side is the parent or caregiver that tumbles down the steps at a mall or they're witnessed by others. That one, they may still have injury, but my threshold becomes higher, not my non-accidental trauma threshold of 80. Does that make sense? All right, moving on. These decision aids are going to we're going to utilize these decision aids to help us decide when we need to image and when we need to increase our suspicion for clinically significant intra-abdominal injury. And we're going to catch most of them if we apply these algorithms, which is great. Interestingly, these decision aids really haven't been compared to clinical gestalt and really not really much better. And it turns out that the upshot says that if you suspect something, trust your gut. It's just as good, it's equally important. You're just adding some objective data to what you inherently already know, and that's sort of what we hone in as emergency people, right? People who work in emergency medicine are gonna be kind of clued into this seems like something's wrong, and trust your gut and instinct. And if you remember, get the labs, get all this other stuff to help arm yourself with more objective data about what you see. Don't let routine labs, don't let routine imaging take away from your overall clinical gestalt and decision making. Now, one of the things I mentioned earlier is the seatbelt sign. Seatbelt sign is bad. It's kind of part of the overall seatbelt syndrome, which we'll talk about next, and chance fractures and increased risk of intra-abdominal injuries. Handlebar injuries, right? We've all seen that. I've had a 17-year-old that came in a day or two later after he got a soccer ball kind of kicked in the abdomen while he was playing and coming in with progressive abdominal pain. These blunt injuries can cause serious pathology. So even if you see these patients and you're like, they look really good and they have evidence of a seatbelt injury, they are at higher risk for intra-abdominal injury, please image them. And by imaging them, I mean a CT scan, not just an ultrasound. I'm going to take a brief moment and talk about my public service announcement, if you will. The AP and the CDC actually recommend certain guidelines for use of car seats in kids. And it used to be, if you remember, I remember when I was growing up, it's like back in the station wagon, the 8-track playing, right? And like, what was a seat belt? It was like, how many kids could you cram in? Everybody's facing all sorts of directions, and it was a road trip, right? Now the recommendation is rear facing until at least 2 years of age, all the way up to 4 or until they outgrow their car seat. Right, my kid does not like me, but he was rear-facing for quite some time. He doesn't like me for other reasons too, but that's a totally different story. Rear-facing until they outgrow it, or when they get their driver's license, somewhere between then. Go to rear-facing into forward-facing to booster seat into just plain. But the important thing when you transition from booster seat to full seat belt is to make sure it fits appropriately. And these are some of the things to consider. It should be across the shoulder midline, not like up against the neck. It should be across their thighs, not across the lower abdomen. Their feet should be able to touch the floor independently of anything else. So even though there are some general guidelines somewhere between 9 and 12 years of age, each child is individualized because their torso height may vary, their leg length may vary, and ultimately the goal is just to keep them as safe as long as we can within the confines of what we can do to protect them. Now after they hit 12, they get other influences, and it's much harder to protect them at that point. But when we can, please consider following the safety belt guidelines that are put out by the AAP and the CDC. Seatbelt syndrome, as I mentioned, is the combination of the above. It's the seatbelt sign in addition to the chance fracture. Remember, this is not just an anterior compression fracture. There's actually a shearing and a ripping of that posterior elements, which causes hyperextension of the vertebrae and causes a lot of morbidity, right? So it's kind of this syndrome of intra-abdominal injury, the chance fracture, and some sort of visceral injury. Those hollow organ injuries can be missed on a CT scan. Right. In rare cases, it can also cause spinal cord injury and aortic injury. And again, Sujit mentioned, it's pretty rare that we worry about these things when it comes to blunt trauma. But if the shoe fits, make sure you scan. There's a bunch of algorithms out there for non-operative trauma of the liver and spleen and non-operative management of the blunt kidney injury. This is for our surgeons and our IR colleagues. At the end of the day, we want to diagnose it to figure out what's what. Now, there is a movement, I will say, within the surgical community of like, why are we getting these scans? Most of these are non-op anyways. It does help them for now to figure out what are the return precautions. What sort of imaging do they need to follow up? They may not operate on a grade 1, 2, 3, 4 liver or splenic laceration, but it will give them some guidelines of when they need to follow up and what kind of imaging they need to obtain, right? How long are they out from those sports? What sort of recovery are they expecting and need? So it will give them a sense of grading, even though many of these patients, especially pediatric patients, aren't being taken for operative management anymore. IR is playing an increasingly prominent role, much like they are in adult traumas, as we move forward. So I anticipate in the next 10 or 20 years, some of this overall approach may change. And interestingly enough, a lot now is already non-operative. But I'm going to leave that decision to our surgeons and colleagues. CT scan is the gold standard. As much as we don't want to radiate kids, it catches most of the important injuries, with the exception of some of the hollow organ injuries, like the pancreas, like the small bowel or the large bowel. So if you suspect it, they're still in a lot of pain, negative CT scan, I still kind of push for an observation, overnight observation for serial exams and plus or minus labs. All right. And the biggest reason that we hesitate is radiation exposure, right? We want to be as low as reasonably possible when it comes to exposing them to the ionizing radiation. So using clinical pathways, such as LFT thresholds, right? Following the signs and the symptoms of blunt intra-abdominal injury, we can reduce the use of CT scan without significantly leading to harm, which is kind of the goal of a lot of these algorithms. Radiation from a plan X-ray is almost nothing, all right? So it's vanishingly small. They get a lot more radiation on the little billion Bluetooth kind of headsets they have going everywhere, right? The one thing is, if you're thinking about, like, I'm just going to get a CT of the lumbar spine or the thoracic spine or something like that, and it comes to kind of blunt injury overall, think about just getting the overall CT of the belly or chest, mostly because the amount of radiation that's just isolated to the bones of the back of the vertebrae is just about the same as it is when it comes to the overall abdomen and chest, and you'll get more detail and information, right? If you send them to a pediatric center, they're able to adjust the radiation doses so the overall amount of radiation received is less, right? So if your institution, you may want to check, our community shop, we actually checked and made sure that we had Peds protocols when it came to CTing for API or injury or anything else like that. They actually adjust the doses and the slices to accommodate for lower levels. That's something you can take home and ask your radiology colleagues. So we're going to miss hollow viscous and diaphragmatic injuries. So if you suspect something, they have continued pain, symptoms, consider keeping them for overnight observation. Here's a couple of pictures of different kinds of imaging for blunt intra-abdominal injury. We're going to zip through that and get to the core of why we worry. This chart is the relationship saying the younger you are and are exposed to CT scans, the higher risk of subsequent cancer. The younger you are, the higher your risk of cancer. That's kind of it, right? The bottom line there on both charts is leukemia, and the top line, for example, on top is brain cancer for head CTs, and the second line on the abdominal CTs there, is right there, is gastric cancers. All right, digestive cancers overall. So the younger you are, the higher your risk of cancer. They have longer to live. We try and avoid it. What about minimizing the risk by doing ultrasound? We use it in adults, right? Why can't we just use it in kids? Notoriously and surprisingly, FAST is unreliable in the pediatric trauma patient. Why is that? It misses a lot of clinically significant intra-abdominal injuries. Some studies suggest even 30 to 50%, right? Those are whopping numbers. So ultrasound positive in the unstable adult patient, go to the OR. Ultrasound positive in the unstable pediatric patient. Kind of depends still, which is a bit of a surprise. Stable patient with a positive FAST, they're stable. Stable patient with the negative FAST, I haven't ruled out anything. So ultrasound is notoriously inaccurate and incomplete because it routinely misses things and it has positives that I don't know what to do with. If you are going to ultrasound, one pearl is, unlike adults when we kind of focus on Morrison's pouch, kids are going to collect in the suprapubic region, right? Especially younger kids, 3, 4, 5, 6 kind of age, right before they hit at double digits, 10 or so. Right? They're going to be more likely to collect fluid in the suprapubic space. But even these are not highly reliable. So bottom line is, unlike adults, we need to use FAST a lot more cautiously when we incorporate it into our overall decision-making for blunt intra-abdominal injury. The FAST and this is actually a nice pictorial. Let me see if I can get this in here. What they looked at is does the FAST change CT use, misdiagnosis, anything else like that. And the bottom line is when it came to abdominal CTs, length of stay charges, admission laparotomies, everything was no except maybe hospital length of stay by about 10 hours. So it may have adjusted hospital length of stay, but otherwise incorporating FAST into your algorithms really didn't change a lot of the parameters that we often use in thinking about these patients. So what do we use to predict? PCARN has an intra-abdominal injury algorithm, just like they have a head injury algorithm. It's by the same group that mentioned those things earlier, right? Abdominal tenderness, seatbelt sign, low GCS. These are all things that follow our gestalt, right? In addition, is there thoracic wall trauma, complaints of abdominal pain, decreased breath sounds, or vomiting? And much like most of the PCARN algorithms, if you say no to everything, you have a very low risk of clinically significant intra-abdominal injury. If you say yes, it kind of depends on what part of the branch point you have. But at the end of the day, use an algorithm. It's available for you. It's used widespread to kind of help us aid our clinical decision making. What do we do if we do? We're going to give them some fluids. Easy enough. Now, this slide mentions 40 to 60 cc's per kilogram to stabilize, but I will say that that is a little controversial because in adults, we've moved to more blood products early on, right? Ideally, we're not giving them any fluids because if they're losing blood, they should get blood. In the pediatric world, we're not quite there yet, but we're moving there. And the 2020 ATLS guidelines is actually recommending only a 20 cc per kilo bolus before you start blood, right? So in kids, we used to give them a little bit more fluids. We're not quite ready to get rid of it totally. And we are moving towards blood. Massive transfusion protocols exist in many of the pediatric trauma centers, and the protocols vary a little bit, mostly because as you pull the PRBCs, as you pull the FFP, remember the platelets come in 6-packs. So you kind of have to find a ratio that works for the delivery of these blood products. Some institutions are using TEG, others aren't necessarily, depending on if they can get things real access or not. But in general, a little bit of fluids maybe for kids, but you're going to move towards blood as soon as you can. All right. And this area is really, really lacking some significant evidence. All right. It's there, but it's pretty small. It's extrapolated for more zones, et cetera, but MTPs follow the protocol. If you're at a pediatric trauma center, you probably already have one. If you're looking to transfer, try not to do more than 20 cc's per kilo of IV fluids before moving to blood products, if available. Hopefully you can get them to a pediatric facility in a timely manner. What about TXA? TXA in trauma is used far less frequently than adults, and again, most of the data has been extrapolated from war zones. This slide said that there's no randomized full trials. There has been a pilot trial by PCAR Network, and they're calling it the TikTok trial. They're going to show a lot of kids post videos of themselves getting TXA. No, I'm kidding. That's not that TikTok. It's the C, TIC, TOC. TikTok trial is actually looking at this exact question. How are we going to use TXA in kids in trauma? Their initial data has been not TikTok specifically, but all over the place. Studies in Japan suggest there may be an increased seizure occurrence, association, not causation necessarily, without any clear benefit. Other studies have shown a small survival benefit. Hopefully, the larger PCARN study, the TikTok study, will give us a clearer answer as far as TXA in children. I'd say many institutions are willing to try. It's kind of up in the air a little bit. What do? The Royal College of Pediatrics does have an evidence statement that uses it. And we don't really know the dosing either. That TICTILE trial is looking at ideal dosing, but there are some pragmatic dosing levels that are out there, and this is an example of one of them, 15 mg per kg over a 10-minute period. When you use these doses, it has not been associated with the seizures that study in Japan noted. What about permissive hypotension? So in adults, we allow them to run low blood pressures with the exception of head injury because of maintaining cerebral perfusion pressure. We allow them to go a little bit lower, systolic of 90, because we don't want to disrupt any clot. What about in kids? This is the one thing that is pretty vastly different in pediatrics, right? We don't really do permissive hypotension in kids. Right? Hypotension is such a late finding, it's such a low threshold. We talked earlier about the 2 times the age in years, plus 70, being such a late finding, 5th percentile. We're not going to wait for that point. We're not going to allow permissive hypotension in the pediatric patient. And overall, low thresholds for transfer. They actually are going to allow us to have an over-triage rate of 25 to 30%. They want those pediatric patients in a trauma center. So if you want to work them up, fine, but please consider transfer early to a pediatric center where they might be able to do a CT with lower radiation, where they have the subspecialists available to make those decisions about operative or non-operative management on some of these intra-abdominal injuries that are sustained. They've been shown that patients sent to the pediatric trauma centers actually can reduce mortality, and that really is the overall goal when we care for these kids. So low threshold for transferring. It's one of the few times you can kind of pick up the phone and get them over pretty seamlessly. One of the findings that they found when you over-triage, was isolated skull fractures. We have moved to like non-management, basically, of those, right? It's like follow up with your PCP with an isolated, linear, non-displaced skull fracture. But that was initially part of the over-triage, and we've kind of moved away from that. And I think that's a move in the right direction. They didn't have any long-term issues and ended utilizing a lot of resources where there was no complications. So those isolated skull fractures, non-displaced, well-appearing, et cetera, can be discharged home with PCP follow-up. Again, I'm going to reiterate, please, if you suspect abuse, if you don't have the capability of a true full skeletal survey and a true read by a radiologist that's capable of reading the 20-plus films this requires, please transfer for a proper evaluation. All right, these kids, I think, are the highest risk because we miss them. We don't think about it, we're going to miss it. Regional systemic systems exist for us to be able to transfer and take care of these kids, hopefully quickly for you, and to follow these established protocols as we move forward in dealing with kids with blunt intra-abdominal injury. The bottom line is go ahead and transfer if you suspect high mechanisms of trauma. You utilize your inclusion criteria, protocols, and algorithms to get these kids transferred across. Low thresholds for abuse to transfer, and lower thresholds for those LFTs, AST, and ALT. When in doubt, it's one of the times I'd say it's better to overdo it. Don't be afraid to call early and often for advice, and thank you again for taking care of these challenging kids.